So my name is Helena Teede. I'm the Executive Director of Monash Partners, and welcome. Great to see you all here. So just to give you a very quick rundown about what Monash Partners is before I introduce you to our esteemed international expert, who's going to tell you a lot that we've been hearing over the last few weeks while we've had the pleasure of her company. So Monash Partners is a partnership across Alfred Health, Monash Health, Peninsula, Eastern, Cabrini, Epworth, Hudson, Burnett, Baker, Monash University. I can almost rattle them off like that now. So in essence, that covers about 2.5 million catchment in terms of providing healthcare services, covers private and public. And the main thing about this partnership is it's different to, we don't do research, although we do a little bit. We'll talk about that in a minute. We don't do healthcare. We do the embedding of research in healthcare, driving healthcare to have better evidence-based impact in practice. And that's a simple, really logical thing to say, but a really, really hard thing to do, because all of our organisations, be it university, hospitals, institutes, are very big silos that have a particular job to do, and their job is not necessarily to drive evidence into practice to improve health outcomes. But they are all funded by your and my tax-paying dollars. And the reality is that we should all have a responsibility that whatever we do is evidence-based best practice, whether we're the researchers driving that or the clinicians delivering that or the health services providing that. One of the really good learnings from around the world is when you want to break down silos and get people to work together, one of the best drivers for that is a really compelling consumer community voice. So when you think about the fundamental fact that in Australia the community is the funder and the beneficiary of research, and they are the funder and the beneficiary of healthcare. And they should absolutely expect, they being us, to have an active voice in our health service provision, our healthcare improvement, and the research that we choose to spend our money on. That hasn't happened, and in fact traditionally research still is in fact very much, I'm the expert, I've got a really good track record, give me money to do what I think is a really good idea, and all I have to do is publish it. I don't have to translate it, and in fact if I go and spend my time translating that research, I not only don't get any credit for it, but I'm not publishing and getting more grants, so I probably won't get more funding. So the system has driven us to be highly competitive and to focus on what we have to have as an output, even if we genuinely want to focus on translation and impact. So it's not that researchers are belligerent and not wanting to do the right thing, but often that the system doesn't actually encourage us to do that. In healthcare, we, especially at this particular organisation, are head down, backside up, beavering away, delivering massive amounts of service provision. Out of our 18,500 employees, 5, in fact not quite 5, EFT, are in our innovation unit. And our quality and safety is a little better than that, but not a whole lot more. So how much of the business is dedicated to just delivering versus improving what we do? And the organisation has an incredible number of pressures, all of our health services do, and those pressures are about delivering what we're rewarded for, which is just large-scale service provision, as fast and as quick and as best patient experience as we possibly can. But where in that system does it say we need to provide evidence-based care? How are we supposed to do it? How are we measuring it? How are we driving innovation? How are we facilitating research? An oncologist colleague said to me recently, you can't practice current oncology unless you integrate research into your practice, because all the new life-saving medications that are really out there are only available if we can have the research in our back pocket. And you can imagine if you're in Bendigo or up at a Buck West, your chance of your oncologist actually having access to those trials is zip. Here you may have a much better chance, but in many places it's nowhere near as good as it should be. So it's hit and miss. So if you have rectal carcinoma at the moment and you happen to be referred to one hospital, your outcomes can be 3 times better than if you're referred to a different Victorian public hospital. And that's not the desire, it's just the system is not up to the best evidence-based care everywhere. And that's only going to get worse as a disparity as more and more evidence and more research seeps into the system. It's about to change because soon the federal government will require hospital accreditation. How many of you are involved in processes around or aware of what happens in hospital accreditation before it happens? Right. Mad panic. Everybody's really aware of what they're going to be accredited for, and they drive to those targets. In the next round of accreditation, 2 of the markers will be about research. So all of a sudden, for our CEOs and our health services, they're going to have to integrate research, not just let it happen, and sometimes fight it from happening, sometimes find it an inconvenience, but actually encourage and facilitate and enable research and show that they're investing in the capacity of that. And at the same time, the health services are going to have to show how they're driving that into practice. They don't quite know how to do that yet. But these centres, which are now funded for $300 million over a long time frame, there are lots of us, so it's not a lot of money each year per centre, but they're now funded $300 million to try and do that integration of health and research and evidence into practice. But to do that, we have to shake up all the silos and work together, and that's hard to do. And one of the key drivers of that is a strong community voice in partnership. Many years ago, as an academic, I was ready to give up academia because my research wasn't having impact, and I was leading a large clinical service and I was having trouble innovating. I was ready to throw the baby out with the bathwater and do something else. But I travelled around the world on a sabbatical looking at how people were integrating the two, and came back newly inspired and ended up running this centre. But one of the main things that we were learning was around the world, people were getting much cleverer at partnering with consumers and consumer organisations. Partnership is not all about saying the consumer or the community is in control and they should decide what we do, because sometimes that's not evidence-based either, and that we all need to run after that. Nor is it about the expert doctor or nurse or academic telling everyone what they should do. It's about partnership and empowerment and collaboration. And when you do it really well, it's actually really exciting. We've got someone here who's going to tell you a little bit about probably one of the most functional partnerships I've seen that's been, and had the privilege of learning with the consumer group to do some of that great work. They raise their own funds, and I'll tell you a little bit about it. They set priorities about what they want the work to look like. They help with a peer review, and they really help with the quality of the research, so it focuses on consumer needs. They help with participation, and they help with translation. It's really quite an inspiring model. And when I tell my colleagues about this, I say, how can consumers do peer review of research projects? You just need to sit in and watch them do it once, and you work out what value proposition they bring. You know, it's fine to say we want to use insulin pumps in this condition, but these patients have really complex lives. Do you really think insulin pumps, which might make one tiny thing perfect, are actually going to improve the quality of their life? Have you gone and asked them whether they think insulin pumps might be useful before you go and do a trial of insulin pumps? So these sorts of really basic questions come into play. So recognising that the consumer voice is really important in partnership, we need to train consumers so they understand their role, which is not adversarial, which is not necessarily just their own personal experience, but as the expert and lived experience as the community voice. We need to train our health professionals to not be their doctor or nurse in this context, but to be a fellow expert. We need to train our researchers not to use consumers and get them to say something so they can prioritise their research, which I've seen happen before, but to work respectfully in partnership. So the training is really important, but we also need to value it, which means we understand what it is, and we're going to hear a lot about that today from Magdalena. And alongside understanding what it is and how to do it, we then need to implement it in the system. And Angela Jones, who is our Chief Operating Officer at Monash Partners, is our lead in consumer and community engagement with our fellows, Sandy Braff and Darsha Sheeny, who are very capable academics who are driving a lot of the work we have at the moment in this area. But the team are starting to look at how we can make it a system. You don't get funded by Monash Partners unless you have genuine consumer engagement in the planning, co-design, prioritisation, execution and dissemination of your work. And soon there'll be a lot more of that creeping into organisations like NHRC, ARC and other funding bodies to say we really need to be much more appropriate with this. Once it's tagged to funding, everyone will do it. So we're starting to get that in, but once we've got the groundwork and the training in place so that we're not pushing people off a cliff to do something they're not ready. So we've got the privilege today. So Professor Skateris, Helen Skateris, who is the Professor of Healthcare Improvement at Monash Uni and the lead for the Monash Warwick Alliance, which is a very prominent healthcare improvement entity in Warwick University in the UK. has been able to get Magdalena Skrybant to come out to Australia for a 2-week secondment to start to build some of our capacity. They do amazing stuff in the UK around consumer and community involvement. We are a long way behind, but we have a second user advantage. So we're going to try and leapfrog and move pretty quickly. So Magdalena's been here for a couple of weeks now and has been talking to many of yourselves to try and explain what they do in the UK with some really practical examples of what that looks like, not just the theory. And I'm going to hand over to let her tell you a little bit about that. And then we're going to have a bit of a panel with some of the consumer leads that we have at Monash Partners, where we hope you will be interactive, participate and ask your questions. Thank you. I'll hand over to Magdalena.
So thank you ever so much, Helena, and to Helen for inviting me over here. And as I said, this brings an end to 2 weeks here in Australia. What a lovely country, what an amazing university campus you've got. And it's honestly been my real privilege to come over here and meet so many of you. So just to explain a bit about my role and what I do. So I am Patient and Public Involvement and Engagement Lead, nice short title, for something called a Collaboration for Leadership in Applied Health Research and Care, another really short title. But my job basically is to facilitate public involvement in all our research projects within one research centre. So I'll just, before we start, I'll just mention to you that there are lots of different names for what I call in the UK patient and public involvement. But I know that you in Australia call CCI or consumer and public involvement. So here are some of the terms that are used. We've got PPI, co-production, user involvement, consumer involvement, all kinds of different terms. But basically, what all these different terms mean is how you work in partnership with patients, their carers, communities in designing, developing and delivering your research projects. So there's lots and lots of different terms. As I said, the term that's used most commonly in the UK is patient and public involvement, which in short is PPI. But we recently submitted an application for a centre and the term there was used PCIEP. So it's a new one for us to learn. But the interesting thing about that is they've incorporated the word community. So public and community involvement, engagement and participation. So you already have the word community embedded in your terms, but certainly that's something we're taking in the UK, that it's about communities as well. We're starting to move away from using the word patient because not everybody involved in our research is a patient. Quite often it's carers or just sometimes members of the public. So I just wanted to explain a bit more about what we call our CLARC West Midlands. And this is very similar to what Helena was describing in the Monash Partners. CLARC West Midlands, it stands for Collaborations for Leadership in Applied Health Research and Care. And basically what CLARCs are partnerships, triads between NHS services. So that could be a hospital trust, a GP, it could be an ambulance service, higher education institutions. So in our CLARC we have 3 universities, Warwick, Birmingham and Keele, and then patients and the public. And we work together as a triad, all 3 of us work in partnership to help design and shape healthcare services. And in our CLARC we have 4 main themes. So the first theme is maternity and child health. We have youth mental health, prevention and detection, chronic diseases, and those are all our substantive themes. And then we have 2 cross-cutting themes of implementation and organisational science, which looks at how interventions are taken up in the services, and then research methods, so how we do the research. And throughout all of these projects, we have patient and public involvement embedded. So people quite often try and conceptualise what patient and public involvement is. There are 2 terms that are used quite frequently. Some people call patients and the public the grit in the oyster, but I prefer the first one, the golden thread. Patients and the public are the golden thread running through every single one of our research projects and running throughout our whole centre. We can't do our research effectively without the input of patients and the public. And I really like the golden thread analogy. So just to talk about our structure briefly and how we facilitate patient and public involvement in our CLARC. So as I mentioned, I'm employed full-time on the CLARC to work across all the different research themes and centrally to ensure that we have public involvement, but that it's not tokenistic, that it's not a tick box exercise, that it's actually meaningful. But just to talk about our structure, as I said, every single project has patient and public involvement. And some of those, it's very easy to see how the public can add value to the different stages of research projects, for example, a trial. But sometimes it's more challenging. This particularly in the research methods project, where we might be looking at developing a particular research methodology or using Bayesian statistics. But we do have patients and the public involved in every single one of our projects. We have 14 public advisors. So these were recruited through an open call, and we had very, very informal interviews to determine who these advisors would be. But it was just to make sure that people were clear on what they were getting into, but that we had a diverse range of people. We didn't want everybody from the same background with the same experiences informing us on our CLARC. We have advisors embedded in each theme. So from these 14 advisors, 2 of them will be on the first theme, 3 of them will be on the second theme, and so on, depending on what they're interested in and their life experiences. So, for example, the chronic diseases theme will typically have people who either have chronic diseases or who care for someone with chronic diseases. Together, this group of 14 meet 4 times a year. They have their own chair. The chair happens to be a former chaplain from one of the hospitals, so he's a very good chair. They meet and I provide updates on the whole CLARC project, but they also provide feedback to me on their experiences of involvement within our CLARC. And certainly if there are any issues, for example, meetings being cancelled or them not getting good communication, then they'll feedback to me at those meetings. But they have their own terms of reference, and they elect representatives then onto CLARC's. We have steering committee that meets every 6 weeks and executive committee that meets twice a year. So they elect representatives onto those committees. And as I said, I'm employed full-time to facilitate all of this work and make sure that there is enough communication between the researchers and the advisors. And I'm a single point of contact. And I can't reiterate enough how important having a single named contact is. Researchers are very busy, patients are very busy, and sometimes things get lost in communication. But I'm there to oversee and make sure that there is a good experience for our public contributors. I should also mention here, I'm not sure if I mentioned it later on, but in the UK, we certainly pay all our public contributors for their involvement. It's quite important for us not just to demonstrate that we value their importance, but we recognise that people give up their time freely to be involved in our activities. So they're not really rates of pay, but we offer an honoraria of £20 per hour for every contributor who becomes involved in our research. And it's up to people to decide whether or not they want to be involved. So they have this rate of £20 per hour, or £75 for half a day, or £150 for a full day's involvement. But it's certainly a very strong principle of ours that nobody should be out of pocket for any involvement activity. So regardless of whether they want to accept the honoraria payment or not, it's important to us that we refund all travel expenses. And any, for example, if they had childcare costs, we'd reimburse those, or carer costs. Okay, so what is public involvement in research? And I'll start off with a key definition that's used in the UK, and this is used throughout, and I think any bid that you see with the public involvement section will have this statement. This statement comes from the National Institute for Health Research and the organisation that oversees public involvement in the UK, which is called NIHR Involve. And the statement of public involvement in research is really clear. It's research carried out with or by members of the public, rather than to, about, or for them. So we're not doing something to patients, we're involving them as part of our research team in designing and delivering the research project. So patients and the public work alongside researchers to shape what research is done, how the research is being carried out, and how the results are shared and applied in practice. So when I'm delivering this talk to researchers in the UK or research managers, I ask them to conceptualise patient and public involvement contributors as members of the research team, and to think about patients and the public as important as people like health economists, statisticians, qualitative researchers. They bring unique skill set, knowledge and expertise that you as research investigator may not have. And it's not something you can read a paper and find out about, because you need to get those unique insights from patients and the public. So when I talk about it, that's how I ask researchers to conceptualise it. It's a member of your team, that you cannot do the research without them. And in the UK, we have 3 very distinct terms, and it's important that we don't confuse these. So we have research involvement, which, as I've said, is doing research with or by members of the public. We have engagement, which is where we share our research and disseminate our findings. And then we have participation, which is where we collect data from research participants. So just to give you some examples of each of the 3 categories. So examples of involvement include identifying research priorities. They can be co-applicants on research projects, or even they can be lead applicants on research projects. A member of a steering group or a management group committee or an executive committee, so that they're involved in any key decisions that are made about a research project. Developing ethics applications or research protocols. Only a patient or a member of the public with lived experience of a condition or caring for someone with a condition will know if your research methods are ethically acceptable to patients or people you'd hope to recruit as participants. Helping to develop research materials. So this could be things like patient information sheets, consent forms, developing your website so that members of the public can find out what research you're doing, find end of project reports, plain English summaries. Your patient and public contributors can help to do all of that. As a co-researcher on a project. So this is used particularly in research where you're recruiting people who are vulnerable. You might want to consider using patients or members of the public to actually do some of the research, but only if they've had relevant training. So we've worked on some projects where researchers have been trained to do qualitative interviewing and have actually done the interviewing alongside a researcher because it makes the participant feel more at ease. Or similarly, it works really well if you have public contributors co-facilitating focus group discussions, for example, and helping to analyse research findings. It's really important that when you have research findings and you have discussions about them, what the researchers and perhaps clinicians consider to be important aren't necessarily the same as what patients and public contributors consider important. So examples of participation. And the key rule of thumb here is someone is a research participant if they are having data collected from them. If you as a researcher are collecting data, that's participation. So if you're doing an interview and you're recording it verbatim and you're having it transcribed and you're using some framework to analyse it, that's participation. If you're collecting anything from the patient, that's blood sample, saliva sample, doing a skin biopsy, that's all participation. So examples could be being part of a clinical trial, completing a questionnaire, taking part in a focus group, and being interviewed for a study as an interviewee, or wearing a device. And this is quite common now. Quite a lot of studies now have some wearable technology, but if somebody's wearing it and you're gathering that data, that's participation. And finally, we have engagement. And the thing to know about engagement is, whereas in involvement you have a two-way dialogue, engagement's very one way. You have a researcher, and by all means you can have a public contributor alongside you, but you're sharing your research and you're just throwing out there, this is what we've done, this is what we're doing. You're not really getting anything back necessarily from the people in the audience. So examples could be public events. So we have science festivals in the UK. We're trying to be a lot more creative in how we engage the public with research. So, for example, I did an event at Grand Central Station, which is a big station in Birmingham, I was chatting to people as they were looking at the departures board on whether they wanted to know about research in the NHS. We have things, being very British, we have Pint of Science, which is where we go out to pubs and we speak to people about research in pubs. We have something that's a bit more bourgeois called Café Scientifique, where we go and talk about research in cafes and coffee shops. And, you know, I do a lot of things, for example, in schools. I've recently done a few events in care villages. So these are not care homes. These are small villages where people get support, and there's everything they could want there: restaurants, cafes, shops. But people tend not to leave the communities. So I go out into these communities to speak to people. One of the reasons I do it is I always get a good audience, because everybody's got, you know, they all say, oh, we love hearing different people. So try and be creative in your approach. We can speak about our research in the media, radio, television, particularly if you've had an important paper being published or some relevant findings. And also it's important to disseminate research to people who've taken part. So if people have taken part in a trial, they should know where they can find the outcome of the research. Certainly in the UK, it's mandatory to publish the findings of research if it's a registered trial. So I'm not sure in Australia, but I assume it's similar. So why do we involve patients and the public and communities in our research? I really like this quote when it comes up. So this is Dame Sally Davis, who was the Chief Medical Officer in the UK and for the Department of Health. And this is what she said, and I really like this quote. It's, no matter how complicated the research or how brilliant the researcher, patients and the public always offer unique, invaluable insight. And it's that unique, invaluable insight that's so important. You can do as much, you can be the best researcher and have all these brilliant track record of publishing and bringing in grant monies, but you can't do the research without those unique perspectives. And hopefully in the panel discussion later, we'll be talking about how important and insightful these contributions can be. And this is certainly a mantra in the UK, nothing about me without me. So this is there's been a long history of public involvement in all areas of the NHS that sort of came back from the rights movement. But certainly in the last 10 to 15 years, there's been a real push for more public involvement in all areas of the NHS. That obviously includes research. And there's this concept that you should be doing nothing to do with health and social care about patients without involving them. And they should be involved as early as possible. So what are the benefits for patients and the public in doing research? Well, there are many. Firstly, if somebody's living with a condition or caring for someone with a condition, they can be assured that the research topics are important to them and are relevant to them. A lot of patients I work with do so altruistically. They want to give something back. Quite often they've received really good health care or have had good experience, and they want to do something for the NHS because they're so grateful for the care they've received. They want to ensure the research is more patient-centred. Helena gave the example of research that's done because it's deemed to be a good idea, but, you know, an insulin pump, but is that what the patient wants? I just read a paper about looking at public involvement in orthopedic research, and whereas there are lots and lots of clinical trials to do with drugs, what the patients want is actually research into physiotherapy, surgery, better patient education, and what patients can do to empower themselves to take better care of themselves. So that just goes to show that there are lots and lots of clinical trials funded on drugs, but that's not what the patients want, or perhaps not what the patients need. A lot of people want to get involved so they can meet other people with similar conditions and similar interests. And while we make it very clear to people that public involvement is not a support group, that's partly why we do the interviews, the informal interviews, we also recognise that for a lot of these people they can be quite isolated, and this gives them a way to get out and meet other people who've got similar experiences. And what are the benefits for researchers? Well, researchers benefit from this unique, invaluable perspective, as I mentioned from that quote from Dame Sally Davies. They get a different insight than things they would get from reading the academic literature and engaging with other academic colleagues or clinical colleagues. And quite often clinicians will think they know what patients want, but actually it's not actually what patients and their carers want. They get this unique knowledge. And also they benefit from having people on their research team who really champion their research. Patients and the public have no agenda. They're not involved in the politics of universities and everything that goes with it, of the challenges of getting research funding, of publishing in peer-reviewed journals. They're just there to focus on your research project. And having that patient champion can be really valuable and important. And they can remind you why you're doing the research in the first place. So here are just some insights from patients and the public, and this is taken from an NIHR involved publication about why people should be involved in research. And these are just some actual voices from patients of why they've chosen to get involved. The quote I like best is the one in the middle, Jim in the grey box, and he says, "Involvement gives you a purpose to stop watching TV all day and going bonkers to doing something to make a difference." So he's obviously sat at home and he wants to do something to make a difference, but people have lots of different reasons for wanting to get involved. So when do we involve patients and the public in research? When's the best time? I'm not going to lie, quite often people come knocking on my door and the bid is due next week and they'll say, "Magda, I need some PPI." I'm like, okay, great. But actually, the key message for this is, when should you do it? You should do it absolutely as soon as possible. As soon as you've got that germ of a research idea, that's when you should involve patients and the public, because you don't want to go too far down the road of developing an idea that's not appropriate. And similarly, you don't want to involve people when you've already formed your idea, got all your research methodology in place, because that can look like consultation rather than meaningful involvement. We have a research cycle in the UK that we use, and you can absolutely use patients and the public in all stages of the research cycle. So this is what the research cycle looks like. And I'll just go through each stage to identify how you can involve patients and the public in the research and provide some examples. So identifying and prioritising research. This is really, really important. There's no use doing research. Well, there is use, but you have to think of why you're doing research in the first place. The research has to be relevant to members of the public and address their needs and priorities. We're all taxpayers, and our taxpayers' money goes to fund this research, so you want it to be something that's going to make a difference. So patients and the public should have a view over what research is undertaken, should ensure that the research focus is relevant to them and their carers and communities. And this can be done in a number of ways. You can involve people in existing networks that you know of, perhaps a university group or a condition-specific group. You can hold an event. If you're putting a grant together, you can hold an event, a workshop or a discussion group, and invite people with those relevant knowledge and expertise to the meeting. You can work with organisations such as charities. They'll help you ensure that your research public is relevant, your research project is relevant. And sometimes you can involve an independent facilitator, which can be really beneficial. In the UK, we have something called the James Lind Alliance, who have these priority setting partnerships. So they'll choose a particular condition or perhaps a group and identify the top 10 priorities in that area. And it's a very long process, but a very thorough process. It usually takes about 10 years. But I just had a look online this morning, and there are over 100 priority setting partnerships that have already taken place or are currently taking place. And they've identified the top 10 research priorities in that particular area. So it could be fractures in people with upper limb fractures, or it could be, there's one, for example, on diabetes in pregnancy. So they've identified the top 10 areas in each of these conditions. In commissioning research, in the UK, this is big business for PPI, because there is no, certainly for the National Institute of Health Research, there are patients and the public on our boards that commission the research. So they'll be involved in developing the call, the commission, but also in reviewing applications and actually on the boards that decide which projects are funded and which aren't funded. And we will get feedback on our patient and public involvement from a lay reviewer, as well as from everybody else on the panel. Each of our, for the National Institute for Health Research, incidentally, each of our applications has a section on PPI, which includes 2 subsections. So the first one is how patients and the public have been involved in designing the study. And the second section is how patients and the public will be involved in the project if the project is successful in being funded. So many funders are now doing this. It's not just the National Institute for Health Research. Other funders are doing this. It helps give a broader perspective. So whilst lots of academics might get excited about a particular methodology or their perceived impact of the project, the public will come at it from a different perspective. Is it providing value for money? Is it addressing a real need? Or is it only a very small community that are going to benefit? And as I said, they're members on commissioning panels or boards. They usually have 1 or 2 lay members on each board that decides whether a project is funded or not. So we have a real incentive in the UK to have good public involvement, because basically if we don't have it, we're not going to get funded. And I'm not saying that's why we do it, but it's a real incentive. It has really helped push the standards, increase the standards of public involvement in our work, I would say. So in designing and managing your project, as I said a few slides ago, it's really important to involve people as early as possible. But patients and the public can have a really key role in designing your research project and helping you manage that project if you're successful. So in designing the research project, not only can they help ensure that the research is relevant, they can help make sure that the research methodology you're using is ethical and acceptable to patients. It's no good you saying we're going to recruit 3,000 participants and we're going to ask them to have a blood test every day if they're not going to be able to have a blood test every day. Or, for example, you might think we're going to do 3 skin biopsies, but unless you know what it's like to have a skin biopsy and the fact that it's really painful, you're not going to retain those patients throughout the study. You need to make sure that your research project is designed in the right way, and you can only do that by speaking with and working with people who've got that lived experience and knowledge of what it's like to live with a condition. They can also help provide support in recruitment in helping to know what's practical and feasible. I was on a project once that didn't recruit. It didn't recruit participants, and the reason was it was a project for patients with rheumatoid arthritis, but where they wanted the patients go to participate in the research had no parking. It was about half a mile walk, and the patients just said, not doing it, sorry. And it was actually, the project fell down, it stopped because it failed to recruit. And actually there were simple measures. And when we asked the researchers if they could have done it in another location, the answer was absolutely yes, but they wanted to do it in the place where they worked, not which was most convenient for the patients. So that was a lesson learned the hard way. But I can provide lots and lots of examples where patients, on the converse, have suggested things that have help recruitment. And it can be knowledge of where to recruit participants from and how to get them to fill in the questionnaire. You know, sometimes they'll say, oh, would it be really nice if you could incentivize them in some way? One project we did, they gave little lip balms to the patients when they completed the questionnaire, you know, just to get them to open the envelope in the first place. And they can also suggest ways that you can involve patients throughout your research project as you're going on. So when you're designing your research project, think about the ways in which public can be involved as your partners in the project. So it's not just designing the research. Can they, for example, help you do the plain English summary? Can they help you design the patient information sheets? Can they help you design the consent form so that people who are consenting to the project really understand what consent is and that it's informed consent? Can they help you design your web pages? Can they help you design an infographic to explain your research in a lay language? Are they going to be used in interviewing patients? There are a myriad of ways they can be involved. And it's about having a good relationship with your public contributors to make sure you maximise the benefit of this patient voice. They also help ensure that your public involvement activities are costed appropriately. Certainly in the UK, when we submit bids, they scrutinise our funds for public involvement. And it's all very well saying we're going to do all these many things, but then if you've got no budget to support it, that'll be picked up straight away. It's important that you recognise that people are giving their time, so they need to be reimbursed appropriately, as well as travel expenses. So managing the research, I talked about what we do on our CLARC. There are no decisions made in our CLARC without a public voice being present. So it helps ensure that there's a constant public perspective, and that's very important for accountability, particularly our current CLARC's £10 million. That's a lot of public money. So it's important that when decisions are made, they're made with the right people around the table. It helps ensure that projects are properly budgeted and funded. Can help if there are problems, particularly with recruitment or retention on trials. And I've said before, they can be members of steering committees, management committees, finance committees, executive committees, but they're key members of the research team. But certainly in most of the projects I work on, every single committee has at least one public member. We usually have two because it's quite burdensome for the public contributor. They might not be able to attend all meetings, for example, but we have members on each of those committees, and partly for that accountability, but partly because we value having that different perspective and insight. So undertaking the research. I just add the caveat here that if patients are being involved in doing the research, there needs to be adequate resource in training them and skilling them up to do the research. Anyone that's done a PhD and been involved in research knows how much training is involved and how valuable these skills are. So you can absolutely involve members of the public in doing the research, but you just need to make sure that they need to have the proper support and training to do so. So here are just some ways that you can involve patients and the public and actually undertaking and doing the research. So they can gather documentary evidence. We use quite a lot of public contributors in systematic reviewing. And one of the areas they can provide real insight is helping to identify grey literature, for example. You can do Google searches, but there's lots of stuff that's not on Google, printed pamphlets, informations that patients with particular condition or knowledge of caring for someone have access to these materials that you might not have as a researcher, for example. They can do interviews, develop research tools. I've mentioned before consent forms, patient information sheets, website design, developing the content for websites, analysing and interpreting research findings. As I've said, what researchers think are important findings can sometimes be different to what patients and their communities think of as important. And disseminating the findings. So certainly this is a really key area where patients and the public can add real value to research projects in sharing the findings. A lot of researchers will have on their agenda ways they want to disseminate and share their findings, and certainly all grant applications in the UK have a specific section on this. And I think every researcher says, we will present at international conferences and publish in peer-reviewed journals. That's the kind of stock line. But this is where patients and the public can add real creativity. Who are the most important audience for your research, and how can you get your research evidence to those communities? Because actually they can take the evidence up themselves and they can be implementers of the evidence. If you found a new care pathway, patients can say, why aren't we receiving this here? This is shown to work. Or if there's a new therapy, this works, when can I receive it? So it's really important to work with members of the public in helping you design your dissemination strategy and also deliver it. One thing patients are really good at is summarising findings. You ask a researcher to summarise their findings and they'll pretty much cut and paste the scientific abstract, whereas patients can put it in much more engaging format and sometimes think about different ways you can deliver that message. And they can also, we involve patients and the public in co-presenting at conferences, for example, or at dissemination events. And I really advocate this because researchers can do a fantastic job in the project and also share that in a really amazing way. But nothing sells a research project quite like the experiences of a patient and their take on how that research is going to make a difference. And that will win the hearts and minds of people in the audience, much more than perhaps a more academic summary of the research. We also acknowledge patient and public contributions in journal articles, and we will absolutely acknowledge patients and the public as co-authors if they've contributed to the content of the academic article. And implementing the research, I touched on this earlier, but it's absolutely important that whilst academics may publish in journals, that next step from getting the research evidence into practice, from moving to what we know to what we do, can sometimes be quite a large gap. And patients can have a really, really important role in helping implement those research findings. And actually it's a case of empowering patients to translate that evidence into practice. Quite often patients and the public bring a real enthusiasm to your research project. So after 3 years or 5 years, if you've had enough, they won't have had enough, and they'll want to make sure that the public money that's been invested into that research actually makes a change to patients and communities. The final point is just evaluating the impact of PPI. We do a lot of patient and public involvement in the UK, but we don't necessarily know what works and what doesn't work and what works in what context, because people often don't report it. The way that public involvement have been involved in shaping the research and developing and delivering the research often goes underreported. But patients and the public can have a key role in monitoring the involvement they do and the impact that involvement has. And we actually have now some guidance that was developed by one of the researchers, partly developed by one of the researchers at the University of Warwick, Sophie Staniszewska, and it's the guidance for reporting patient and public involvement. And that's part of the Equator guidance. So that's a standard framework for reporting PPI. There are 2 forms, a short form and a long form, so there's no excuse now for people not to report their public involvement in a systematic way. And finally, I'd just like to finish with this quote from Hal Williams, who was chair of one of our commissioning boards. And this is his take on public involvement. So he said, "We see 2 types of PPI in our applications. Genuine PPI, where it's clear how researchers have worked with patients to plan better research for the NHS, and token PPI, where a patient has been drafted in to agree with the team's preconceived ideas. Try to be the former." And that's certainly what we try to do in CLARC West Midlands. We really try to embed patient and public involvement in everything we do. And part of my role is working with the researchers and with the patients and the public and communities to develop those relationships that can make that a reality. So thank you. So I'm happy to take questions, or if anybody has any.
I'm curious, when you said before about, some of the more challenging sorts of projects and how you might involve consumers or the public in them, like innovation statistics or something, how would you do that?
So we have genuine discussions with our public contributors. First of all, we identify who's going to be interested. And you'd be surprised, lots of people come. A lot of people think of patients as public contributors and that's the only hat they wear. They forget that they have other lives and other interests. So we find out who's interested. And we have conversations with them about how they might like to be involved. And okay, they might not be involved in the doing of the research. They're not going to be doing any complicated Bayesian modelling or anything like that. They might do, but I've not come across that yet. But it's more often in things like, how can we communicate this research? And what are the key outcomes of the research that are going to be important to patients? And sometimes that involves quite a long conversation about directly the patient isn't going to benefit from this Bayesian modelling, but actually this will then help improve this, which will improve X. And it's helping us communicate that, because sometimes we don't know the best ways of doing that. So that's an example. Just before I came out, I did a discussion group with members of the public, and the researcher who came to me initially, her research is on testing the accuracy of diagnostic testing mechanisms, like the scanners and things, and how sure can we be that these are as accurate as they say they are. It was really, really complex. And she was just like, I don't know what to do with my PPI. But we had a discussion group and it was absolutely fascinating. And some of the insights the patients one of the things was the researcher was surprised that everybody assumed that when they have the test done, they're all amazingly accurate. And they had no concept of false positives and all this kind of stuff. So there was an amazing discussion. And the researcher went away with so many ideas. But I would say, even if it is challenging and you're scratching your heads, invite people along anyway and see what comes out, because you'd be surprised at the kind of insights and perspectives that patients can bring. When I said we need to be sure that we're costing research, we're costing public involvement effectively, absolutely we have to do that. So if we're working with, I know you call them cold groups, but in the UK it's underrepresented groups, we make sure that we cost appropriately. So we'll include costings for things like translators, interpreters, if that's what required for a project. It's slightly more challenging in developing a research application because you haven't got the funding yet. So how can you involve those communities in developing a research project if it's going to require extra resource? So in the UK, when we're developing research applications, you can apply for short seed funding. It's only £350, but if required, we'll find the extra resource, for example, from the CLARC, or to make sure that we do have the relevant resource. That being said, it's not easy to get into those communities in the first place, and that's where you have to really think outside the box in the ways you do your public involvement. So a traditional model in the UK of let's have a discussion group at the university at 3 o'clock on a Wednesday afternoon and see who turns up. You're not necessarily going to bring in those communities. So that's where you might go out into a community setting and try and involve people that way. And quite often they'll say, oh, we've got some people who are bilingual who'll help you in those early stages. On every application would have to indicate how the consumers are supported in their roles and are as enabled as they would want to be to be involved in our research. So typically, first of all, they have a named contact. So it's not always me. It might be on smaller research projects, it's the lead researcher or a researcher. They must have a single point of contact and a named person that they can call up and email if they've got any concerns. So that's the first point. Secondly, we always do an induction, and the induction has two parts. The first part will be an induction to the research project, and we do things like have photos of all the researchers, all their contact details, plain English summary of the research, and we sort of do a sort of shorter version of a Gantt chart so they know the key milestones in the project. The second part of that induction would be an introduction to public involvement in research. And I do things a bit like I've done today. What's the difference between involvement, engagement, participation, how they could be involved in the research cycle, but make it relevant to that research project. Every single public contributor has a sort of manual for the project, which has on the first page all my contact details or the PPI contact details, all the information they've got about the project. And then some templates at the back that they can fill in so they can record their own involvement activity and what kind of exercises they've done and what they've got out of it, because it's important for us to, support them in what they want to do. And that's important for our reporting. We also do a learning needs analysis. So after we've done the presentations, we ask them if there's anything they would want support with. And I give them examples. So it might be presentation skills, it might be committee chairing skills, or it could be something like qualitative research knowledge about that. Or, for example, I've just done a project and we've delivered a session to the public, the people involved in our research. They're using a discrete choice questionnaire. So we're getting the researcher who's very experienced in that to explain to them what discrete choice questionnaires are, so that they can be involved in developing those questionnaires as part of our study. But the key thing is ongoing support. It's not just one day at the start. It's constantly checking up with them. Are you feeling you're as involved as you want to be? Is there anything we can do to support you?
So, only I've been speaking to Angela. Basically, Monash Partners has a national alliance across all the centres. We have co-developed with the Consumer Health Forum a national framework for consumer and community involvement. We have 4 bodies of work. All of the centres will have an ambassador and then a consumer and community involvement committee, and also like a COLD committee. We have just funded training available to all the health services for culturally linguistically diverse appropriate healthcare for Indigenous perspectives, and Jackie's leading an initiative to look at developing that for other cultural groups. The consumer and community involvement in healthcare improvement and research training resources, we are the national lead in developing that. So Dash and Sandy have had a critical role in doing both the systematic literature reviews, so what we do is evidence-based, but also doing really great qualitative research with consumer groups who all have the same problems, and with advocacy agencies who will have the same needs. So we're actually going to provide a forum for them to network with each other, learn from each other, to network and be involved with us, but to also co-develop the resources that they all want, but would have had to all do individually. So all the health services will be involved in that through the committee that you're on. But the point is it will all be done and just be done once, and it'll be done for the country, but it's being led from here. So hopefully that will resolve it. And we partner very closely with Warwick. Helen's over there all the time, and I go quite often as well, and Magdalena will be working with us, so we'll make sure they're well informed.
One thing that does work really well is we have a buddy system. So people who've been doing public involvement activities for quite a while, a number of years, will partner with people who are fresh into it, have never done it before, and they have their own informal networks, because quite often it'd be nice to hear from someone who's actually walked the walk and has experience of going to a meeting first time with 20 professors and not knowing what to say, or being frightened about what feedback to give or how to be critical, or all that kind of stuff. So but the PPI buddies also, I quite often buddy researchers who are new to PPI with public contributors who will help them work well with their public contributors. Someone experienced who can say, best to do this, don't do this, avoid doing this, this is send a Christmas card because that's a really nice personal gesture, that kind of stuff. So our buddy scheme does work well. But obviously it's all quite resource intensive, so that's just useful to bear in mind, but I think it pays dividends in improving the experience all round. So.
Hi, I just wondered in your training of researchers and organisations that use consumers, whether you include the aspect of when the funding finishes or the institutional organisation withdraws their support of consumers, because I've seen that being done quite badly, where the consumers were so invested in the project and then it finished abruptly and it wasn't done in an ethical way.
Yeah, well, I suppose that's where a role like mine is important, because I'm not tied to a particular project, I'm tied to a centre. So when a research project finishes, that researcher might then quickly move on 6 months before a project ends. They've already got their eye on their next career opportunity, and that public contributor can sometimes, you say, be left a bit high and dry, thinking, well, I've invested all this time, that's it now? So that's where having a centre with a group that's continually going, it's important, because it means that the public contributors have something else they're part of, and it's my job to help signpost them to future opportunities or work throughout the centre to continue their interest and involvement in that project. And I've always got my eye on lots of different opportunities for different contributors. So if they, and opportunities, for example, a project's ended and someone's got all that knowledge and skills and expertise of being a public contributor, I might say to them, do you want to be a buddy for a new contributor? Do you want to help co-develop training with me? Constantly provide other opportunities for them. So I don't provide specific training on that. I do provide training on ethically involving contributors to make sure that you respect them and value them. But that's partly what my role is, to sort of pick up, when a project's ended, what else can they be involved in?
Right, so Julie has had a long-term partnership which is really involved. We've worked together and really to tell you a little bit about how that works.
Thank you. So I'm Julie Norman, and I've been involved with Monash Partners for over 4 years now, and Monash Health as well. So I have a 16-year-old daughter with cystic fibrosis, and for those of you who aren't aware of what that is, I thought I'd give a quick summary. So it's a genetic inherited disease. It's only a few decades ago that it was considered a childhood disease, and we've just crossed that there are more adults than children, but it's still an incredibly complex chronic condition. There's still about 1,200 different gene mutations. Be perfect for, personalised medicine, because there doesn't seem to be a single cure for all or treatment for all. Everyone is just so different. So while in Australia there's about 2,500 people, half are in Victoria and New South Wales. So in 2011, with two other mums, we decided that there's not enough research done in Australia for cystic fibrosis. And we decided that we actually wanted to create, I'm getting my words right on this one, how do we create a sustainable culture for CF research in Australia? I'll say that again. So as three mums with a scientific background, how do we create a sustainable research for CF in Australia? So we're all had professional backgrounds, none of us medical. So the first thing we need to do is get money. So we started a 65-kilometre walk. We've been going now for 7 years and we've raised over $750,000, so this happens every year. So we found at this point though, finding money is one thing, finding a research partner who you can work with is another kettle of fish. So we're now on our second partnership, we're extremely happy. But it's how do you find the right research partner for us was really important. We had to understand our values and our aims, and we had to have a partnership that actually worked with us. So we'd all spent years of actually throwing money basically over a research fence. You never heard what the project was, you never heard the outcomes, and we were determined that wasn't going to be us. So we run our own website. Every project we fund is clearly on the website, who the money's gone to, the amount of money that they've received, and the closeout. So for us it's really important to keep all our donors in the loop, and we think that's partly why we get such a small population with CF in Victoria. There's only 850 people, about 800 people. How we raise so much money, it's because we're totally transparent, and that was really key for us. Our partnership, I think, continues to evolve every year. Every year we sort of add something to it, and I'm glad you mentioned the James Lind Alliance, because last year they published CF findings, and so last year we actually brought the top 10 and then there was another top 20 into our research workshop. So we have a research workshop every year, second year will be this year. The other thing that was important for our group is we have people across Victoria giving us money. Yeah, there's a great division in Victoria of two sides of the river as far as research institutes and hospitals. So we were determined that we wanted all of Victoria. So Monash partners were fantastic. We had RCH in the room, and people from MCRI were also invited. And it's really important for us that the whole of Victoria can participate in our research workshops. We have researchers, clinicians, allied health, nursing staff, consumers, and it's pretty open, also a good mix of university staff and hospital staff. So it's trying to get that holistic centre. And through that we find, so there's a lot of projects as consumers we might want, but then a researcher will say, oh, that's happening in North Queensland, so we can sort of write that off. And also there's, it goes the other way as well, that there's a lot of things that researchers might think are good. And for us with CF, the burden of care is always front of mind. So you do hours and hours a day when you're coping with something like cystic fibrosis. It doesn't take much to pivot that into a totally unmanageable situation. So every output needs to be completely manageable. So we find our annual meeting with Helena and Angela really joyful. So we actually meet once a year with the outcome of all of our projects. I should have mentioned that Monash actually run our grant process. They obtain all of our peer reviews for research projects. Ultimately it's the consumers choosing, but we would never choose something that had a poor peer review. So we really use that as the first hurdle. Really has to pass that hurdle of having good scientific evidence and being well prepared. But then we meet once a year and actually go through everything and decide on the project. So I think that's a wonderful experience for all of us. I think we learn every year and make ourselves a bit smarter and a bit better every year. And I think we'll continue to evolve, and that's all part of the process. So no, I think we're in a great position. I can see we're actually going to continue to move this partnership forward for as long as the three of us can continue to raise money anyway. Yes, and hoping too that we're always happy to fund a small seed project, and I hope it will grow to a bigger project. So that's the other important part of us. It's just giving some bits of seed funding that will grow. And I think that's it for me, so thank you all for listening.
So my name is Dashan Yaton, and along with Sandra Braff, we are the Monash Partners Consumer and Community Involvement Fellows. And basically, we started in January, and both of us have come from both a research background. We're qualitative researchers, but we're also educators. So we are very passionate about curriculum and training, and how do we build the capacity and empower people to do this type of thing well. And so when we first started the program, we were like, oh, what training is out there? And so we did a systematic review, because that's what researchers love to do. And we found that the literature doesn't actually describe the training that well. And often they'll say things like, oh yeah, the consumers were trained. And we're like, trained in what? The researchers were trained in what? And so it's trying to understand what those components are. The second piece of work we're doing is because, you know, consumers are really, really important. I've loved hearing about your process of setting this up. And so we've been going to consumer organisations and consumer groups who are involved in research and saying, well, how do you want researchers to actually engage with you? And what would be some things you'd like to tell researchers, but also how can we train and how can we equip you and how can we empower you? And just hearing what these consumer organisations are saying has been really interesting in helping us then craft what we will put into our training programs. And things that, as Magdalena said, we wouldn't have necessarily thought about. In terms of how do you support a consumer, how do you engage in an organisation, how do you choose the right consumers for the different types of roles that they may have throughout the research cycle. And we're also talking to researchers and, interestingly, the ethics committees about how do we also empower the researchers to do consumer and community involvement really well. And so that's what we're doing this year. Both Sandy and I have done a lot of qualitative research, and I just wanted to put out the reflection that Magdalena has said, that it's become very clear that a lot of researchers just think qualitative research, where you're talking to people and doing interviews, is consumer involvement. And I think it's been a really good distinction, and I thank you so much for sharing it, that if you are collecting data, that is participation, that is not involvement. And unless they've been involved in all the aspects of the research process, get them involved in looking at your interview questions and whether or not that's a good thing to be asking and the phrasing has been right. Just being able to illustrate that to researchers so that they can understand that distinction has been helpful.
I'm Teede Boyle. I'm the Deputy Director at Monash Centre for Health Research and Implementation and lead the Women's Public Health and Health Equity stream. And I also have quite a strong collaboration with the Menzies School of Health Research in Darwin, and I think my role is just to talk a little bit about how we've been doing some community involvement in research. I think that actually I learned a lot from working in the Northern Territory, where, for example, they have an Aboriginal subgroup for the ethics committee, and if they reject your ethics application, the main committee won't approve it. So you really have to seriously look at your consumer involvement in your research. I think that so I think that it's great to actually, I think that there's going to be a framework rather than individual people and groups trying to do it. So I think we have to, and we've built a lot of, I think when someone asked before, we have built a lot of links with groups outside hospitals and research in communities. So Multicultural Centre for Women's Health in the South East, National Migrant and Refugee Association, a lot of those groups which have really helped us in setting up some of our community groups. And I agree, I think that once you start using community groups, it really opens your eyes. So first of all, in terms of what you actually do, so in the involvement in setting some of the priorities. And everyone always says how hard it is to work with migrant and refugee communities, and once you have a community group that is on board with you, it completely changes, and it really makes it so much more accessible. And they will suggest, we've been to festival days with communities and things that, we wouldn't necessarily know were happening. We've been to play groups, a lot of things that you just wouldn't even think of that the community groups get you into. And then if your recruitment's not working very well, or if people aren't answering your questionnaires very well, you go to them and they'll go, oh, well, that's because, and it's so obvious to them and it hasn't been obvious to us. So we've definitely learnt a lot. And in terms of also help with dissemination, social media, apps, lots of other things have been fantastic. We're doing some talks at community libraries through the council. So I think that it's been a really great process, and my group's really learnt a lot, but I think we're really going to value having that structured framework and systemic support. So I think that'd be really great.
So I'll just say a few extra words and we'll open up to any questions. So I would have to say that my experience over the last 10 years has very much been about, if you only look at the problem from your perspective, especially when you think you're an expert, you'll only see the problem from one lens. And it's actually really important that we have consumers, both consumers who are what we would call a lead capture, for example, the Natural Heart Foundation advocacy person, as well as representative, whether it's cultural linguistically diverse or the general population or vulnerable groups. You need to capture both, but the consumer voice is really genuinely important, as is the health professional, who often is not an academic, but therefore doesn't have a role in your initiative. So we need to make sure a health professional is not the same as an academic health professional. So having an academic, having health professionals of different disciplines, having consumers, both elite and representative, and often health service managers who have to be in a position to do this. So how do we get all the people around the table and actually work out what the problem is? From multiple perspectives, you often see a very different problem. And then the pathway to solutions often a very different pathway. And that's happened to us many, many times, where we thought we were going to do X, and as the years have changed, our thinking has really gone back to the point that we're not even going to decide what we're going to do, or even that we know what the problem is when we go on a pathway. But once we do, we take a really big picture strategic approach and start with stakeholders and end up with stakeholders through a cycle of bringing in clinical research, through guidelines and national policy standards, through to collecting and measuring data, through to implementation science, and then healthcare improvement in the hospitals. The big problem at the moment is if you're a clinical researcher, and I've just read the documents from our leading clinical researchers in the country that tell me how they're going to transform the entire health system through clinical trials. If that were the case, we would have done a lot more than we already have. It's really important, but on its own, it doesn't do it. People who love guidelines write guidelines and they sit on shelves. People who love data write beautiful algorithms, develop the data systems and look at the data themselves, but they don't share it with the hospitals and the people who have to use it for transparency, and God forbid with the participants whose data that it actually is. The implementation scientists have developed almost a perfect science to make it so academic that you almost can't understand it. There are 98 frameworks. And healthcare improvement people often are completely devoid of evidence. They don't look at clinical trials, they don't look at guidelines, and they sit there doing PDSA cycles, improving something, but it's probably not evidence-based. So there are about 9 different silos around that journey. That is a learning health system. Nobody puts all of that together, even though it's absolutely common sense. So we've actually trademarked that learning health system. But the point being that we're now breaking down all those silos and really shaking them up, and we need consumers to stand in the middle and hold us all to account and tell the trialists you're not going to fix anything unless you get your evidence into guidelines, and the guideline people, you're not going to fix anything unless you make sure you've got measurable metrics that we are actually collecting data for and reporting back, and the data people, that you're not going to fix anything unless you're feeding your data back, and the implementation science people actually working to improve outcomes, and the healthcare improvement people actually putting evidence into practice. So it's about how you bring all of those together, and I personally believe that consumers have a critical role in holding us all to account. I also think they have a very critical role in holding policymakers to account. How many of you worked with policymakers? Right, it's great fun. And I think one of the critical things is that policymakers are actually quite beholden and sensitive to a community voice, but often they don't hear it enough to be held accountable to it. If we go to government and we go with a strong, well-prepared, genuine patient and public involvement agenda, and we do it well, then rarely do we go wrong. If we go into government saying, me too, please fund me, and everybody else is bashing at their door saying, please fund me for this, and this is the right way, and this is my group, they either don't pick it all, or even worse, they just pick one group of winners, and it remains in one silo. So we're doing a lot more work with consumers and community to bring that consolidated voice to policymakers and to hold them accountable for their choices and their decisions. So just over to anybody who would like to ask a question. We have one microphone, I think, so we're going to have to tag team.
And I'm a neurologist, and I've done a lot of research on stroke prevention, and we're just starting a guideline for carotid artery disease because we've done a systematic review and they're all procedurally biased and out of date with respect to lifestyle and medication. We can do a lot now to prevent stroke, just those non-invasive measures. But we would like to get consumers involved. We don't have any funding for that, and I'm just wondering, we're just starting out, if Monash partners or the university, how do we get started with the resources that might already be there to help in this situation?
So by the end of the year, not right now, but by the end of the year, we will have some training resources, and Dasha and Sandy will be developing them with us over the next 6 months. So the training will be there, that will be available. At the moment, there is not a funding source nor a requirement to fund public and patient involvement in Australia. So most of our PPI or CCI is currently unfunded. Whether that will change or not, that's not something the framework has dealt with. So we have to work through that. The NHMRC has agreed that public and patient involvement, or CCI, is actually a fundable item. You can now put it in your budget, your grants, but that's very different to what you're talking about. At the moment, we don't have a system to do that, but it may be that moving forward we might look at a seed grant situation like Magdalena was describing, of basically giving people startup funding to do co-design work. That will not fund extensive consumer involvement in eating guidelines. So that doesn't necessarily solve your problem, but it will at least start to move a bit towards that.
I was just going to say, just because you don't have the money doesn't mean you shouldn't do it. If you are clear with people about what the expectation is, how you want them to be involved, what impact you think their involvement is going to have, I'm sure you'll have people who have either experience of stroke or caring for someone with stroke that will want to do it because they'll want to improve the experience for other people. So I think it's absolutely possible to do, and whilst there's no funding yet, there are other things you can provide for people. You know, I said it's not just about, when you involve people and work in partnership with them, it's not a one-way relationship. You might be able to provide them skills, experiences, opportunities. So actually it's worth thinking about what you can offer them that's not necessarily cash or money, but for example, can you open doors to them that might always be closed, or quite often people want to get involved because it's more knowledge about their condition, they get to meet clinicians. Some people want career experience, job experience. So actually, I would say, even if you have no money, advertise the opportunities. And if you're creative and you advertise it in the right way to the right people, I'm sure you'll have people who would want to be part of your project.
I think, for example, even having things like parking waived when they come to Monash, and having something to eat. Like, we haven't always been able to pay a lot of ours, or it's very minimal. It might be $30 or something. But most people are very grateful if maybe even minor costs such as transport and parking and things are covered. And I agree about the skills development. There's a reference group that I've been involved with for a number of years, and the skills they have gained and the confidence that they have now, and they're super assertive now. It's fantastic. So I think that people do value some of that as well. So I certainly think it's worth having a go.
I'll also just say, sorry, and I'll pass it to you, Julie. We're going around talking to consumer organisations. I haven't spoken to the Stroke Foundation just yet, but the ones that we have spoken to are very keen for people to come talk to them and at least have those initial conversations. And so you can go into the consumer group and saying, hey, how can we do this? How can we approach this? And getting their advice. And most of them have already said to us, we feel like our remit is to link researchers and clinicians with our consumer base. So I would go to them.
Sorry, just finally, I've found that often the times that you guys want meetings is totally inconvenient for anyone trying to work and do consumer work at the same time. So what I find is some of the best consumers I know, they're also employed. So they're also, I think, because they're at a certain level in the workforce, it lets them think more laterally about problems, and therefore they can contribute more to you, but they want after hours meetings.
Reciprocity is important too. So Magdalena talks about they wanted to get mums to help with some of their pregnancy research, so they offered a yoga class for mums who are pregnant, and they got it was a reciprocity thing. It didn't cost anything, but it was a way of giving back. So there are some innovative ways you can do that. Someone else had a question.
My name's Annette. Thanks for your presentation. I'd actually just like to bring the message back to researchers and how they're being educated in the first place, especially doing science. I've been involved in medical research and scientific conferencing for over 15 years, and education of scientists as well through fresh science programs and national science weeks and so forth. And I've really seen a great emphasis on universities Australia-wide, and I'm sure internationally, on being able to present your work to a lay audience and be able to then communicate with a lay audience and make yourself more touchable to a lay audience, because I think people still fear science and fear research when they don't know a lot about it. So I've actually been really impressed, and now I'm lucky to work in this space too, managing a teletrials project we're running with La Trobe Hospital. But I'm really seeing the benefits of being able to work with people now who can communicate better and understand the value. So I think putting that into the research education at the very early stages, whether you're doing your PhD or your undergraduate degree, is fundamental to be able to make this work better.
I think that's a really good point. I've been working with some consumers in co-design, and the biggest thing that, and they're on my research team from the very beginning in the proposal stage, where we couldn't offer them any money, but we offered them so many hours and parking, and then we were funded so we could pay them for the duration of the project. But the biggest thing they taught me as a health professional, as a researcher, was about my language that I was so unconscious about. I'm working in the mental health space, and so I was using mental illness instead of mental health issues, and I wasn't really using recovery-based sort of language and things that were so unconscious to me I had absolutely no idea about, and putting it into that lay language is really important, so it's just added so much to our team.
Well, we might wrap it up there. Thank you very much for staying. 5 o'clock. Thank you very much to Magdalena for coming all the way over here and helping us, and Julie, who's always been a fantastic participant. In fact, I might take this opportunity to say our reciprocity to the CF group, and we haven't talked about this actually, is that we have been funded to drive clinical innovation. And what that means is we have these rooms full of people where we put doctors and all these very, very clever IT and biomedical engineering and a whole lot of other people in a room, and the doctors stand at the front saying, or the nurses, if only I could do this, I need you to get me a device that will allow me to do that. And then they all work together and come up with these really amazing ideas, and the first one of them has just been picked up to market at $30 million. So these are starting to come through with really fantastic things that will be amazing for patients. But recently, Angela and I were brainstorming, and we said, you know what, it's great to put all the medical people up front, but actually, how about the patients and how about their carers, and why don't we put them up the front and actually get them to tell us about what their burden of disease and caring is and how we might develop things that would help them, like a humidifier who does this and a wheelchair that does that. And so given our long partnership with cystic fibrosis, one of the first groups we're going to put forward to have that opportunity is going to be the CF groups. And we have funding then to fund seed projects that will start to be able to develop up some of those ideas. And that was just completely left field, because all of this innovation around the world is done with health providers rather than with the people who are doing the caring and the burden of disease. And the idea from that came from actually Julie discussing with us that, you know, the research is great, but nobody actually addresses the problems we have dealing with the burden of caring at home. And we went, we've got an idea. So I just want to thank Julie for the, she does a lot of this for us and we really appreciate it. Obviously Dasha and Sandy are doing a lot of great work and may come around and see you, but I hope we'll develop resources that will help you all. Jackie's a fantastic inspiration in the cultural, linguistically diverse and Indigenous space. Angela, who's our Chief Operating Officer who organises things, and Gillian, who's our Comms Manager. Have I forgotten anyone? No? Okay, and Kathy is one of our lead project leads. But I just want to say thank you to everybody, and hopefully we'll be able to help you a lot more moving forward in this area. Thanks.